get started. By now you have the review objectives, and there's two sections. We had the integumentary or the skin pathology, and we had musculoskeletal pathology. And when we started off with the skin pathology, the first thing we opened with is we talk about the key skin types and structures. And what it is that when we looked at the epidermis, I pointed out to you that there were four predominant cells: keratinocytes, Langerhans cells, Murdock cells, and melanocytes. And in your notes, you need to read that section and understand the characteristics of each one of them, because what I'll do is I'll give you one of the characteristics or functions, and you've got to be able to identify the cell that I was talking about. And one thing, and so when we talk about the keratinocytes, we talk about the fact that in the epidermis, because they produce some keratin, which ultimately causes the keratinization of the skin, therefore they synthesize chromofibrils. We talked about melanocytes. Melanocytes are responsible for producing the melanin granules. They produce the melanin granules, but what they do with them is they transport it to the keratinocyte, and there, in the keratinocyte is where the melanin granules form a sort of a supranuclear cap, which protects the keratinocyte from UV light. And we talked about the dendritic Langerhans cell, which basically the main function is to recognize and to process antigens. And we also mentioned to you to the point that the counterpart to the dendritic Langerhans cell, in other words, the cell that's found in the dermis, this cell that's found in the epidermis, the cell that's found in the dermis is called what? The dendrocyte. That's also in the notes. And finally, we talked about the mystery cell, the Murdock cell, that we're trying to figure out, is it primarily tactile mechanical receptors, is it neurosecretory, or is it both? So read that section in your notes, and like I said, I'll describe a function, and you've got to pick the cell that regarding the function or the characteristic which is described. Does anybody have any questions on those cell types? Okay. Next, we went into your notes. You have a page, and I think it's on page 3. That's right. When you have all these definitions, what I've done is from microscopic terms, I will give you the definition, and I'd like you to give me the identify which of the terms we're talking about. And the reason why these terms are important in dermatology is that we talked about this during the class, the fact that the skin is one of the few organs we can actually visualize. And it's between knowing how to describe it macroscopically, what you see, and what you see microscopically, that both of these terms are important in coming to what the final diagnosis is when we're talking about dermatologic conditions. Now, rather than repeat all of these, were there any of these specific terms that anybody had some questions about that they wanted to ask me about before we go on? They're pretty well defined in your notes. All right. The third question, you're going to be given a case scenario, and it's going to be about psoriasis, which we pointed out in class is a chronic liver disease characterized by persistent epidermal hyperplasia, and it produces these large erythematous scaly plaques which have a silver white surface. And we talked about the fact that if you compare normal skin to psoriatic skin, remember all those definitions I gave you on page 3? Psoriasis is one of the best ones to study because it talks to you about acanthosis, which is a hyperplasia of all the layers of the epidermis. It talks about parakeratosis, which talks about keratinization and retention of the nuclei in the stratum corneum. It demonstrates the elongated reedy bridge, and the elongated reedy bridge is simply the fact that the epidermis reaches down into the dermis in a more, you can say, in a more abundant way than it does in normal dermis, with these fingers that go down into the dermis that you see here. And the hyperkeratosis simply means it's you have increased keratinization of the stratum corneum. The other thing that we wanted to point out is in this slide, is that when you look at the reading edges, you notice that you have epidermal hyperplasia here. But in psoriasis, where the dermal fingers come up, there's a thinning of the epidermal cells, and this thinning is associated with denudation of capillaries, and also you have the neutrophils, which then travel up into the layers of the epidermis. And if those neutrophils accumulate in the stratum corneum as a microabscess, what's it called? A microabscess of Monroe. So those were a couple of things that I wanted you to remember about psoriasis. And on the fourth one, when we talk about pemphigus vulgaris, the paragraph that I key in on your notes is the paragraph that talks about when you talk about pemphigus vulgaris, what's unique about this condition is that it is one of the few dermatologic conditions that manifests itself first where? In the oral mucosa, in the mouth. And then it is weeks and months later where you will then see the skin manifestations of this disease. And the other thing I seem to point out to you is that you rarely see the blisters of this disease because this disease has flaccid blisters. And what I did was when I explained to you about the pathogenesis, is the reason why this has flaccid blisters, and by flaccid blisters, we talk about blisters that rupture easily. So by the time the patient comes in, when the doctor is going to take a look at the patient, these rupture so rapidly, the doctor will rarely ever find a blister intact. It will rupture because they rupture very easily. And the reason they rupture very easily is because cleavage occurs in the epidermis very high in the epidermis. And if you remember correctly, if you remember from the class I gave on the pathogenesis of this, is that there's a protein on the surface of the epithelial cell and desmoglein, and this protein is more concentrated in the upper layers of the skin. And because it's concentrated more in the upper layers of the skin, the pathology, pathogenesis underlying this disease is the fact that the body has antibodies against the desmoglein. And because it has antibodies against the desmoglein, it basically causes this cleavage in the epidermis of the site. And the way you can see this is if you do immunofluorescence. You basically outline the outside of the keratinocytes because the antibodies are going to the desmoglein, and the desmoglein is on the surface of the keratinocytes, and therefore when you stain the entire surface of the keratinocyte, and you get this, what they call is a lace-like pattern that is characteristic of this condition on immunofluorescence. Then going on to the next condition we discussed, item 5 on your notes is bullous pemphigoid. Now, whereas pemphigus vulgaris has flaccid blisters, this condition has tense bulli. When this patient goes in, the blisters will be evident, and the reason for this is that it has a deeper cleavage. Its cleavage occurs in the basement membrane zone, in the lamina lucida, and therefore, when this blister separates, it's taking everything. I mean, you have the entire epidermis down to the lamina lucida, and for that reason, that blister tends to be tense. One thing I wanted to point out to you is that the inflammatory cells that are present that you find in this condition, and actually in the blister, eosinophils are most important. Does anybody remember why the eosinophils are most important? It's because it's the degranulation from the eosinophils, that is the eosinophil peroxidase and major basic protein, that cause the lysing of these anchoring filaments that are in the lamina lucida of the basic membrane. That's why the finding predominance of eosinophils on microscopy is important in this condition. And we explained earlier that the pathogenesis of this disease is due to the fact that you have antibodies against what's called bullous pemphigoid antigen 1 and bullous pemphigoid antigen 2. And it's because you have antibodies against them that causes the release of also complement, which causes mast cell degranulation, which attracts the eosinophils, which then causes the damage. And let me just tell you, if you simply focus on and read the entire paragraphs that I've listed in your notes, you'll get basically the important points that you need to know for the test. I am perhaps going a little bit more in detail when I'm talking to you here, but what you need to focus on is in the paragraphs that are specifically listed on your notes. Okay, and that's bullous pemphigoid, and because of the antibodies against the bullous pemphigoid antigen 1 and 2, basically you can see them line up in the lamina lucida and of the basic membrane, and also this staining is also highlighting the IgG as well as the complement, which is released that initiates the process. Okay, does anybody have any questions on any of the points that we've covered on the skin pathology? Okay. Then let's go into the second block of instruction, which was the musculoskeletal diseases. The first condition we talked about was osteoarthritis. And what I want you to focus on is understand the pathogenesis. Which actually starts here. And realize that at the heart of osteoarthritis are the pathologic chondrocyte and matrix changes that occur. In other words, that is what's primarily happening. That is what's breaking down. It's a disorderly repair of this injury that in fact causes osteoarthritis, which you basically see here is a good demonstration. It causes the chondrocytes ultimately fall out, and you basically have loss of the cartilage and the underlying bone literally showing. And as we talked about in class, you will then have bone grinding on bone from the opposite, and this tends to call hibernation of the bone and destruction of the joint, as you literally see in the sequence described up here. And also described in the note of pathogenesis. On the next point that I wanted you to be aware of is when we now transition, we've just talked about osteoarthritis, in which we're talking about problems with destruction with chondrocytes and destruction of the cartilage. We then go to rheumatoid arthritis. And in rheumatoid arthritis, different form of arthritis is destructive. In this case, it's the hyperplasia that occurs in the synovium. Remember, the synovium is more or less that connective tissue membrane that surrounds the joint, and it secretes the lubricants that allows the joint to move frictionlessly. And however, if you take that synovium and you inflame it, like you do in rheumatoid arthritis, it creates a pannus. It's an inflammatory membrane, and this inflammatory membrane literally goes across the top of the joint, destroying the membrane, and also stimulating fibrous bands to go from one joint, from one side of the joint to the other side of the joint, and those fibrous bands ultimately become ossified, so you have a bone protrusion going from one side of the joint to the other, and when you have that, you begin to have fusion of the joint. You don't have that bony fusion in osteoarthritis, which you get in rheumatoid arthritis. But what I want you to focus on for the test specifically are the characteristic histologic features. And that was basically the process that I just defined to you and is defined in your notes. Know these features, and because what I'll do is I will alter 4 of them and only leave 1 of them true. So make sure you understand those histologic features of rheumatoid arthritis. And then, in the course, we also talk about the common, founded